Hello, and welcome to episode 3 of RTMatters, the place where candid conversations about what matters most to respiratory therapists takes place. I'm Patrick Dunn, your host, and I'm delighted to welcome you to our podcast. Now, before we begin, a few housekeeping details to attend to. First, all of our episodes are available on our website, RTMatters.com. It's open access, no charge, no subscription, and no membership requirements. All there for your listening pleasure. And we want you to tell your colleagues about it as well. Second, when you open up on your tablet or your desktop to RTMatters, you'll notice on the top left-hand side of the masthead, next to the logo, an icon saying send your feedback. That will allow you to communicate with us to let us know what you think about what we're doing, what your thoughts are about this or any prior episodes, and more importantly, what we can do better and what really is important to you respiratory therapists. RTMatters is here as a sounding board for all respiratory therapists. It's a virtual voice for RTs, and we're looking forward to hearing from you. Now, on to this particular podcast. For our topic today, the episode is RTs addressing gaps in COPD care. And I'll tell you why I think this matters more to respiratory therapists in a moment. I'd like to introduce our guest panelist, Wendy Frasia. She's the manager of Respiratory Care, EEG, and the ECMO programs at Crouse Health Multi-Hospital in Syracuse, New York. She also played a key role in the development of the innovative Lung Partners program at Crouse, which we'll talk about. And I also want to point out that they are the recipient, their department, of the prestigious 2021 Mitchell A. Barron Achievement Award for excellence in aerosol drug delivery and airway secretion clearance. And it really was an honor to be able to say the organization received that excellent, very, very prestigious award. Now, one of our features, and by the way, Wendy, welcome to our podcast. And one of the features of RTMatters is to have our guests start off by telling a little bit about how you first learned about respiratory therapy.
Well, at first, I knew nothing at all about a respiratory therapist, and I was visiting my grandmother in the hospital in Sarah, Pennsylvania for a few days during a college break. She was admitted for COPD exacerbation, and I can still remember the faces of the respiratory therapists. I was so impressed by them. They had such knowledge of her disease that I had no knowledge of, and I just was impressed by the manner they cared for her.
So the moral of the story for our listeners is someone is always watching what you do, so you always want to be the best you can be, especially when they're members of the patient's family. Now, where were you at that point in your personal and professional life when you actually saw this respiratory therapist taking care of a family member?
Well, I was on a summer leave. I was a college student at University of San Diego. I was on a business path, and I was moving to an advertising program at Syracuse University. But that summer, I made a decision to change career paths, and that was my best move ever.
Right. You figured respiratory therapy might be a great career option based upon your experience personally with a member of your family. Well, as it turns out, you obtained your associate degree in respiratory therapy in 1986. And since then had held various clinical positions at Crouse, and you soon after you graduated, you obtained your registry. However, you also returned to school later in your career and obtained your baccalaureate degree in 2015 and your MBA in 2021. What prompted you to continue your education above and beyond having your registry and already gainfully employed?
Well, I always knew I wanted to further my education. In that gap there, I had 5 children while I was working full time. So education took a back seat to that, unfortunately, but it was all good. So I received my BS in Community and Human Services, and then I wanted to see more of the whole picture of healthcare. So I then got my master's in Community and Economic Development, and then I went on to get the finance piece of it. So I got my MBA in healthcare. Mm-hmm.
So really preparing yourself. I also pointed out, again, you mentioned you're having a full load here. You're a family member. You have your mom, you're a mother, your wife, you have your job. You're also volunteering for the New York State Society and the AARC. How do you find time to do all this? And why was that voluntary excellence so much part of your career?
Because I thought long and hard that summer, and I decided that if I was going to make this my career path and go off my original path, then I was going to be all in. And to me, that meant that I needed to be involved. So I was involved for a short time, and then I got hooked on it all. And I wanted to see the big picture of our profession. Then I wanted to help more to make a difference and move our profession forward. And I'm at that point now where I see so much progress that's being made, and I just want to be a continued part of furthering that even more.
Right. One of the things I learned, I'm sure you mentioned this before when we were talking earlier, is that when you go into these volunteer organizations and serve on committees with fellow respiratory therapists, we're all respiratory therapists. All of our work environments differ. So the culture is different in each hospital. So it's a good way to communicate and share experiences, but also learn about what other people are doing differently. So like you say, it really enriches your ability to improve what you do in your hospital. Okay, well, now let's get on to the main point, Lung Partners. Let's give our listeners a brief overview. First of all, the program was launched 20 years ago, and I want to go ahead and let people know that they can actually read an article that you co-authored along with Russ Acevedo that appeared in the April 2023 issue of Chest Magazine, where it identified Lung Partners using respiratory therapists as a primary care model. Could you kind of just give us a brief background about how that program developed and why?
Sure. So we knew that we had a respiratory shortage at the time. We needed to create some efficiencies in the department and free up time. Dr. Acevedo had this great idea for this lung partner disease management program using respiratory therapists as the primary caregiver here in the hospital for that patient, communicating with other caregivers and creating a plan with those other caregivers. So we do that. We assign a respiratory therapist to everyone that is enrolled into Lung Partners. That is their primary therapist. They do have a secondary. That primary therapist then sees them at admission for every day that they're here, and then every other admission that they're in for. So it builds a relationship. It builds trust. We learn that patients' barriers to staying healthy at home. We provide a full disease management assessment, med reconciliation, anxiety, depression screening, health literacy, right, quality of life, all those screenings, among others. And we get that full picture of the patient so we can better serve them and be prepared for what they're prepared for at home.
I believe this also probably started just about the time that Medicare started penalizing hospitals for excessive 30-day readmissions. And you guys went a step further. You took the entire patient management system to handle. If the patient comes back in for a readmission, say 4, 5, 6 weeks later, beyond the 30-day, do the same therapist still see that patient?
So the same therapist does. We put a flag on their MRN number so we know when they enter the ER. So we like to meet them there to see if we can prevent an unnecessary readmission, knowing that patient as well as we do. So it's really a partnership.
That really works out well for the patient because now they have a comfort level working with someone who they worked with in the past, and they know that things are going to go very well. Well, now the question comes up, why discuss this on RTMatters? RTs do an excellent job, but here's a reason that we wanted to talk to you some more. There was an article published by Keller and colleagues a few years ago in the Journal of COPD. Actually, it was in January 2022. And they reported on a retroactive study they did of over 600 records, outpatient records in 2 clinics in the Seattle area. And they looked at 6 domains of COPD optimum care. And looking at the number of entries made by primary care physicians and COPD patients during their visits, they surmised that the optimum level of care for COPD patients was suboptimal. And I'm going to quote here, and they went on to say, in a cohort of adults aged 40 years or older who are clinically diagnosed with COPD, we found that the overall outpatient COPD care quality was poor. They said perhaps including pulmonologists more might reverse this trend. Then they went on to say, however, there is a shortage of pulmonologists, so we might basically do a better job by expanding access to pulmonary specialty care for patients by incorporating alternate care providers. And they specifically mentioned nurses and pharmacists. Nothing against nurses and pharmacists, but what screamed up at me, what about respiratory therapists? And that's why I'm delighted to have you here today, so our listeners can figure out how much respiratory therapists can do to address these gaps. Now, the first gap that they identified was the lack of spirometric data to confirm the diagnosis, which is the FEV1 forced vital capacity ratio of 0.7 or less. but then also to declare or define the degree of airflow impairment for future reference, which is the FEV 100% predicted. How does Lung Partners address this big gap in terms of the biometric data being available in the patient's record?
So the initial order includes spirometry if not performed in the past year. And if it's done outside our facility, we would reach out to that provider and have it faxed to us. If it's not done, then we wait till they're past their acute phase and we would perform the PFT testing here. And then we use that along with GOLD guidelines to stage their disease.
And then that becomes your baseline for future evaluations of the patient's progress.
Correct.
See, at best, I think 30% is really a higher number than it is. I think it's much lower. So what you folks are doing is you're really going down the right way to confirm the diagnosis, not just the symptoms and the risk factors, but actually confirming it with spirometry, which is important. And that was a big gap, according to Keller. The other one that he mentioned, second particular domain, was the absence of any entry in most of the charts about smoking cessation. And I guess the reality is that you have to continually at every interaction nudge the patient to make sure they're still not smoking. How do you handle that in terms, especially if they have a relapse?
So we have a very extensive initial assessment. We assess smoking cessation needs there, and then every visit that we have with the patient, so that primary therapist or secondary will assess that. We have a nicotine replacement order set. We discuss with providers, what's appropriate for which patients. And then we work with them also throughout on a plan that's going to work for them outside the hospital.
Now, what about e-cigarettes? I see some literature about the fact that that was identified once as an alternative to cigarette smoking, nicotine replacement, but yet I guess vaping is now becoming somewhat of another problem by itself.
It is. We are working with high schools on that.
Well, what about your COPD patients for smoking cessation? Are you having any success with nicotine replacement via vaping?
No, we do not have that on our order set. I don't know if the providers outside of our facility are using that, but it is not one of our options.
Yeah, we probably just use the nicotine replacement, the gum or the patches, and then also and the lozenges, exactly. Well, it's really important. We want to make sure these patients, especially when they start to feel better, they tend to think, well, maybe I can just sneak one cigarette. And of course, as you know, one of them is on the way down the rabbit hole of more and more. So it's an important observation to make. And then another gap that made the third one was the respiratory symptom assessment. And as you know, the GOLD guidelines are very particular in terms of the need for ongoing assessment. COPD is not a one and done. And some of the assessment that should go into it is if they can use their inhaler, if they're controlling their dyspnea, if their activities of daily living are decreasing, all of which are symptomatic of a deterioration. And how do you reevaluate your patients once they leave the hospital and move out into the community?
So we do phone follow-ups for when they leave our hospital. That is our only option for Lung Partners. We do not have a home care entity. We do have home care agencies that will help us out at times. But we do work with the patients here. We do a lot of education. We discuss any change in condition before they leave to see if we have to change any of their inhalers or their other medication devices and their OPEP devices. We use the teach back method. And so we are pretty secure in the fact that we have educated them to the best of our ability when they leave. And then we work with them via phone or in their primary care office once they leave.
One of the advantages I can see, and I'm hearing in your voice, is that because the patient has a familiarity with that therapist, a lot of this is re-education, reinforcing what was covered the first time, which of course is much different than having a one and done, having the patient just receive information and handouts and then leave. This is a little bit more like nurturing and continuing and supporting.
Yeah, we spend a lot of time with these patients. We have chargeable codes built in for the hours that we spend with these patients.
Mm-hmm. And what did the patients and the families tell you? Did you get any feedback about how much this education helps them manage their disease?
Yeah. So we have something called Simply the Best. They're notes that patients and families can write back to the hospital. We get a lot of those regarding our patients and our therapists and the time that they've spent with the patients and how much they've learned from them to manage their disease. And they feel calmer about things, understanding what they're doing with the devices they have at home.
Yeah, one of the points you mentioned earlier was that you also look for the patient to see if there's any signs of clinical depression or cognitive decline, which of course would interfere with any educational message. And I know that's a very important part. And some therapists say, well, that's not my job. I'm not a psychologist, but it's disease related. So it certainly is in our domain.
Yeah, we screen for that, and then if they meet criteria, we send it to the psychologist.
Yeah, it's so that basically about 60% of COPD patients might have some impairment, cognitive impairment, and it's not surprising. They're elderly, so there's a tail off of normal function anyway. But then there's also high CO2 and low oxygen levels, and all of that gets in the way of optimum cognitive functioning. So you're right on. That was one of the points that was brought up very seriously by Mayer and others. Now, the other one that he identified, the fourth measure of dysfunction in the Keller article, was the lack of oxygen saturation studies. Do you titrate the patient to see if indeed their oxygen, if they need oxygen before they go home, and how do you handle that in the hospital?
Yes, so we have continuous monitoring of oxygen sets throughout our hospital if needed, but we do check their O2 sets with each patient encounter that we have with them, and we also check it during ambulation with PT or bedside exercise if they can't ambulate. So we do screen them for all of that, and we also screen them for nocturnal O2 use or need if they require it.
So you basically know what their oxygen status is from the time they come in, and then you take them off oxygen to see if they can maintain their own saturation, even with some mild exercise. That must really make it easier for you to make a referral to your home oxygen company that you send these patients to.
Right. There are a lot of rules for that. So yes, we get all the information together and then give it to our care coordinators, take care of talking to the home care agencies.
And will they deliver oxygen to the hospital if the patient requires ambulatory oxygen?
I have allowed the home care companies to keep oxygen in our department so that we have a quick way of getting the oxygen tanks up to them.
Wow. That's called continuity of care. You know, basically it's nice to have it there, and that way everybody can get what they need and the patient can go home. That's what they want to get out of that hospital as soon as possible, and they don't want to wait. But at the same time, if they go without their oxygen, they're really kind of not in the best possible condition to recover. Yeah. We'll be right back after this feedback. Hi. You're listening to RTMatters. I'm Patrick Dunn, and today we're interviewing and talking with Wendy Fascia about the Lung Partners program at Krause Hospital in Syracuse, New York. We were talking about the identified gaps in COPD care, primarily for patients who are in the outpatient setting. And two last gaps are, one of them was the absence of a pulmonary rehab referral. And as we all know, along with cigarette cessation, smoking cessation, and pulmonary rehab, those are the two elements that really have prolonged the lives of COPD patients if done effectively. Only 5% of COPD patients get a pulmonary rehab referral. How do you address that particular gap, Wendy, with your group?
So we do have pulmonary rehab in our community. We don't have a great amount, but we do have it. We work with providers to refer those patients that will meet the criteria and those who are willing and able. So it's difficult for many people, with chronic disease to either get to their own appointments that they need to go to. So many are just not able to get to pulmonary rehab centers on a consistent basis. And then as well, many with chronic disease, like we talked about, are depressed or anxious and isolated. That happens a lot with patients with chronic disease. And so that also plays a role in them not attending sessions. So that's a big part of it.
Do you have a pulmonary rehab program at Krause?
We do not.
No. Okay. The other thing is there's an awful lot of discussion now about, especially because of COVID, having virtual pulmonary rehab where the patient, because of whatever reason, cannot leave their home or the pulmonary rehab program is too far away. Do you have any firsthand observations of patients getting virtual pulmonary rehab versus in person?
I don't, but I have been looking into that because I'm very interested in seeing how that plays out. We're always looking to add to our program, and I have a lot of support from above. So
No, see, that's it. You take one bit success and you build on it. And of course, the virtual pulmonary rehab would allow you to continue to have that face-to-face interaction with the patient, especially with the smart devices out there. One of the pushbacks that I've heard, and I think you're probably already investigating it, is that what you miss with virtual is that person-to-person camaraderie that they have when they go into a pulmonary rehab program face-to-face. But at the same time, if they can't get there, virtual is certainly better than nothing.
Correct. I agree.
Okay. So you have a lot of ideas and going on. Now, the last item that Keller was concerned about missing in his record review was what they call the failure for guideline concordant pharmacotherapy. That's a mouthful, and it basically means that COPD patients tend to not have the proper medication prescribed and not the proper device that they can use. So let's take a difference. The difference between a short-acting and long-acting. Just give our listeners an update between the two types of classifications.
So the SABOs, short-acting bronchodilators, are albuterols and Xopenex, and we use those for rescue. And then our long-acting are our maintenance drugs, our LAMAs and our LABAs.
And the patient comes into the hospital, they're in their worst, they're probably in the emergency department. And so consequently, you're using short-active beta agonists as aggressively as you need to get control of the situation. The patient is not well enough to be sent home. They're admitted to the floor, and they still need their short-acting. But then after a couple of 24, 48 hours, they stabilize. What happens at that point in time with your Lung Partners program?
So we have a protocol that allows us to move them from, if they're on a LABA, LAMA, and SABA schedule, we move them to a LABA, LAMA with a short-acting on a PRN only basis. Mm-hmm. So we take away that routine scheduled SABA and we make a PRN.
And one of the arguments is, and the GOLD guidelines are pretty specific, is you really want to get these patients used to taking fewer treatments at the fact that it's going to last longer. We know most of the time when they first with their disease, more is better. They're using their albuterol inhaler 4-6 times a day. And now, of course, it's PRN. And if they're using it more than once or twice a week, that's a sign that they're not being controlled. So you have a nice opportunity to get these patients comfortable because, like you say, your therapists are always there. Even though the patient is only getting 1 or 2 treatments a day, they're still being visited several times a day. Correct. And that's really important. That's a very important point because a lot of our colleagues have said, well, if I'm giving less treatments, I'm going to lose my job. No, that means you're going to be redeployed to do other things that are most important for that particular patient. Do you see that? I mean, do the patients recognize you're just making an educational call, education visit, a follow-up visit, how they're doing? And it really kind of makes the nursing staff feel a lot more comfortable, I would imagine, as well.
Yeah. And the patients, COPD, like I say, a lot of isolation, so they love to chat. Mm-hmm. So just making them feel more comfortable that way. And you can learn so much more about them and what their barriers are just having those conversations.
Now, are you using nebulizers or are you using inhalers when you administer the medications to your patients?
So at Krauss, we are an inhaler medication, MDIs, SMIs specifically right now. If the patient is in respiratory distress or the medication doesn't come in a nebula, in a MDI form, then we will give them a nebulizer. All our vents or non-invasive get nebulizers through the Aerogen, but other than that, everybody gets an MDI.
With a spacer, I would imagine.
With a spacer, yes. And we have those with masks. And if they can't do that, we have an in-check device that we measure inspiratory flow.
That's my next point.
And not use that, we will certainly put them on a nebulizer. We just feel that our MDI routine and the way we educate the patient is a much more effective way of delivering medication.
Yeah, well, the MDI is with a valve holding chamber is a lot more forgiving than the dry powdered inhaler, which they have to have, as you know, the maximum inspiratory flow rate of 60 liters per minute. And a lot of people, when their FEV1 gets down into the 50% of predicted, can't generate that because of dynamic hyperinflation. Now, what happens when the patient is going home? One of the pushbacks we've heard from colleagues in other hospitals is that the hospitalists and the intensivists, they really are uncomfortable writing a new prescription They pretty much like the patient to stay on what they were on and let the attending physician that they go back to make the change. But that's putting them back on what was going on before they failed. So how do you get new prescriptions written and at the same time transfer that information to the patient's primary care physician?
So lucky me, my medical director is chief of medicine here, and he explains our role very well to the providers that work here, and we have a great relationship with the providers that work here. We also have a great relationship with the providers that work in most of our outpatient programs around here. And so if we have to, we can call them as well and tell them that the patient just cannot pull from the medication device that they have given them in the past. And that's part of the reason they may have ended up here.
Yeah, this is really an important point, because the problem is that a lot of physicians are aware of the medications, but as respiratory therapists, part of our DNA is you have to be able to use the delivery device effectively to get the maximum effect of the medication. And a lot of times when the patients come in, they just are not using their device properly. And they're great medications. Right. Dry powder inhalers are great platforms. Problem is 6 or 7 different steps, each time in sequence, must be done properly. And I like to say with any inhaler, you get 1 or 2 breaths to get it right. With a nebulizer, you have anywhere from 8 to 10 minutes of tidal breathing. And so you're going to get a lot more medication in for those that can't generate the flow for their dry powdered inhaler. The patient able to take their inhalers home with them once they leave the hospital? All right, so they're reused and sanitized in the proper way for next patient then?
We do common canister here, except for our isolation and our vet patients.
Mm-hmm. And what nebulizer do you use? The breath actuated nebulizer?
Breath actuated neb. That was part of our initial efficiency creation way back starting in 2001.
And why that particular platform?
Well, for us, it allowed us to decrease treatment time because we knew that the patient in breath actuated mode of the nebulizer was getting much more of the medication than they would with a standard nebulizer. So we dropped the dose on that. And so that decreased our treatment time. And we did not have any extra PRN treatments related to that. That's all spelled out in our published.
Oh, that's right. Yes, you have several abstracts I should point out to our listeners, not just that wonderful article in Chest, but over the years you have provided many open form abstracts and also had articles printed in Respiratory Care. So this is an ongoing program. And one of the other points I wanted to point out that you really stress, and that is the need for ongoing quality improvement assessment of your program. Could you bring us up to date on why you are so obviously favoring transparency to try and see if you can make an improvement? And you have made improvements, I understand.
Yeah, we decreased readmissions at the very beginning and have maintained that. And now we're looking at pneumonia readmissions. The hospital is looking at that and trying to prevent those. So that is an extra arm we're placing on our Lung Partners program. So we're looking at including that as well now.
Success building on success, which is really, and pneumonia, of course, especially with the elderly population, is a real problem because of the high incidence of, it's not like COPD where you catch it from one another. Pneumonia is an infectious disease. And so consequently, this is putting us where we need to be, which is nice to see. How has the staff responded to the fact that they are now, as Dr. Acevedo, which we'll talk about in a moment, allowing them to practice at the top of their license? And I think that's a wonderful compliment in terms of this program.
It is. And I think it just drives them more to want to do more. So we keep adding things on to our Lung Partner program. Like you said, we do, we have a awake and walking ICUs. So our respiratory therapists are part of walking our patients on ventilators. So we have time for that now. And then, they strive to do more. We've always had our airvos, or not airvos, and vapotherms or other high flow nasal cannula on our medical surgical floors, decreasing our ICU days. Staff is always striving for the next item on their list. We're learning now lung ultrasounds. So there's always something new,
Sure.
and it looks like they're engaged, and I think they feel respected, which is huge for respiratory therapists. And I think that just moves us all forward.
Yeah, it really is nice to hear that the therapists don't mind doing less neb treatments. And I hate that term, neb jockey, because it's so pervasive in other hospitals. The physician orders it. They want their patient to be seen, but yet the patient really doesn't need albuterol. They need long acting. And they say, well, if I don't have those treatments to do, I'll lose my job. And here, what you folks have found out is you can redeploy the therapist to other activities and assume more value-oriented tasks in the process, which helps professional growth as well as the morale boost. Do you have any students that come through Krause from the respiratory therapy training programs?
Yes, from the SUNY Upstate program next door is a bachelor's program, and we get them also from Mohawk Valley Community College. And at times when they come here and they fill out an application, they'll tell us that it feels like home, which I really like to hear. They're a very involved ICU physician staff who really very pro-respiratory, so I think that helps us out.
One of the big problems that the educators have to deal with is that the students will go through a rotation through one hospital and see things done a certain way. Maybe the morale isn't too high, and there's a lot of, well, we do it this. And then they come to a place like Krause, and it's like night and day. And I think that's something that you all have to deal with when the students first come there. You have to kind of dispel, this is not how it is at other hospitals. And I think that's probably part of your orientation to the students.
Yeah, we tell everybody that every hospital here in town or wherever they go has something special, and they work in their own way. And we are just a little different with some of the methods that we use.
Now, let's talk about Dr. Acevedo. He was the brainchild of this. Is he fully retired or semi-retired now?
He's fully retired from Krause. He's still here every once in a while. I see him. I saw him the other day.
Yeah, it's really fun because he is so passionate, and I've gotten to know him over the years, and he just really is so much an advocate for respiratory therapists. So this program couldn't have been designed by another guy and by a better team member than you and Rob and the rest of the folks that developed it. It really is a testament to your professionalism. Well, we're moving to the end of our time now. Any final thoughts about the opportunities for respiratory therapists nationwide in terms of taking care of these COPD patients where we have all these gaps that simply are not being addressed by anybody else?
I think you just need to show that you can make a difference, start the conversation. There's those quality measures that catch the eye of senior leaders and other stakeholders, like length of stay, cost per case, ICU days, patient outcomes, readmissions. If you can make a difference in one of those, you'll catch their eye, and you can start there. And hopefully you'll have a new initiative that they will agree to. And if you show your data, you can move on to something else if it's positive.
Yeah. And again, I point out your program is now 20 years. So it's not going to happen overnight. And I just, and you should be very happy that you've got the success behind you. And like you say, it's now a platform for perhaps virtual pulmonary rehabilitation, perhaps looking at the pneumonia patient population. And I wouldn't be surprised if you find out something else to do with your ultrasound evaluation. Well, that brings us to the end. Wendy, thanks very much for spending time with us. And if anybody has additional information that they would like, if you can let us know on RTMatters.com, we'll be happy to send you copies of the articles. They're all in the public domain. And Krause Hospital has always been sharing all their information. It's available, I believe, a lot of your protocols on the AARC's site library for COPD care. And I thought it was very generous. Dr. Acevedo said at the very beginning, this is open access to anybody who wants to go ahead and do it. And I think that's just a testament to how professional this whole organization has been.
You can share my contact information as well.
Sure, no problem. Go ahead. Why don't you give us your address then?
My email address is...
We'll put your email address on the episode when we publish it.
Perfect.
All right. Well, that brings us to the end of this episode of RT Matters. Thanks, Wendy. And we want to thank our guests and the new listeners for tuning in. Remember, we do want to hear from our listeners about what you liked and what we can do better. And if you want more information about the program at Krause, drop us a line and I'll be happy to send it to you or put you in contact with Wendy. Simply log on to our website, rtmatters.com, and click on the feedback tab at the top left side of the masthead. Now, in the meantime, why don't you go out there, as Wendy said, be the best possible respiratory therapist you can be, because you never know who's watching. You might be able to influence some other people to come into this beloved profession just the way you take care of their family member or their loved ones. And our patients deserve nothing less. And after your shift, just think about the next shift coming on. So always leave your workspace equal to, or probably in some cases better than you found it, because you want a clean handoff. This is professional behavior that we want to do. We want to make our oncoming shift just as comfortable as we are when we're leaving the hospital. So next time, until we see you again, be kind to yourself and to others. And remember, RTs do indeed matter. And I leave you with one final thought. I found this interesting, and you'll probably remember where it's from, I'll tell you. It's the quote, life moves pretty fast. If you don't stop and look around once in a while, you would miss it. And that's the last line in the movie Ferris Bueller's Day Off. So you want to go ahead and take time to enjoy life. Until next time, take care.